Hello everyone, welcome to this medicine lecture series in rheumatology, and in this video we will be covering the autoantibodies in rheumatology. This is a very important topic as far as all competitive exams are considered, be it NEET, PG or INI-CET. To start off the discussion, let's begin with the classification of autoantibodies. So they can be of two types. They can be anti-nuclear antibody, which are simply known as ANA, or they can be anti-neutrophil cytoplasmic antibodies, which are known as ANCA or simply ANCA. Now, anti-nuclear antibody, as the name suggests, target the cell nucleus, while anti-neutrophil cytoplasmic antibodies target the cytoplasm and cytoplasm of WBCs, typically of the neutrophils, right? Hence the name anti-neutrophil cytoplasmic antibodies, right? Now, ANA again can be of two types. They can be non-specific ANA, which are simply known as ANA, or they can be specific ANAs. Now, specific ANAs can be of different varieties. They can be anti-dsDNA, anti-RNP, etc. Right? So we will see different types of specific ANAs later on in this video. Similarly, ANCA again are of two types. They can be cytoplasmic or C-ANCA, or it can be perinuclear or P-ANCA. So now let's take our discussion to the different types of ANCA antibodies. Now, C-ANCA is typically directed against the proteinase 3 or PR3 antigen, while perinuclear ANCA is typically directed against the myeloperoxidase or MPO antigen. So now how to remember this? Remember this mnemonic CPR, right? Either remember CPR or remember PM. Choose any one of these and you will automatically remember the other one as well. So CPR means cytoplasmic ANCA and PR3 antigen, while PM perinuclear ANCA and myeloperoxidase antigen. So CPR and PM, that's how you will remember the antibody and their target antigen. Now, cytoplasmic ANCA are predominantly positive in GPA, granulomatosis with polyangiitis, also known as Wegener's granulomatosis. How to remember this? WC, World Cup, right? So C-ANCA and Wegener's granulomatosis. Everything else is in P-ANCA, be it microscopic polyangiitis, MPA, Churg-Strauss, which is also known as EGPA, right? Eosinophilic granulomatosis with polyangiitis, this is known as MPA. So MPA, EGPA, crescentic glomerulonephritis, and even inflammatory bowel disease, all of these show P-ANCA. So Wegener's granulomatosis has C-ANCA, everything else has P-ANCA, right? Now moving on to the staining pattern, C-ANCA have a granular cytoplasmic staining. Of course they are cytoplasmic, hence they will have granular staining, while perinuclear ANCA has perinuclear or nuclear staining. So this is quite evident from the name itself. Now these are the images of the immunofluorescence staining pattern of C-ANCA and P-ANCA. The image itself is not important. What you need to remember is this table, right? So what are the target antigen and what is the disease in which they are positive. This is just for reference, not important that much. Now moving on to the non-specific anti-nuclear antibody. So non-specific ANA is typically the most sensitive antibody for autoimmune connective tissue diseases like SLE, systemic sclerosis, Sjogren's syndrome, etc. And since they are the most sensitive, they are the best for screening the patient, right? Most sensitive antibody is best for screening the patients for autoimmune disorders. Compare this to specific ANAs. They are most specific for certain autoimmune condition, hence they are best for diagnosing or confirming the diagnosis of the autoimmune condition, right? Because they have high specificity, while non-specific have high sensitivity, right? So I have prepared this list of all the important specific ANAs, right? So let's start off with the important ANAs in vasculitis. Anti-alpha enolase is specific for Behçet syndrome, while anti-endothelial cell antibody is specific for Kawasaki syndrome. Then we have the important ANAs associated with SLE. Here we have anti-SM and anti-dsDNA. These are the specific antibodies for SLE, and thus they are best for diagnosing SLE. Here also remember that anti-SM is the most specific, right? Even more specific than the anti-dsDNA. Then we have anti-C1q and anti-dsDNA, which are correlated with SLE disease activity or flares. So anti-C1q is more has a better correlation than anti-dsDNA, but both of these are associated with flares. And anti-dsDNA is also correlated with lupus nephritis. So anti-dsDNA we have studied 3 times. It is the most specific antibody, not most specific but specific antibody for SLE. Then it is correlated with the SLE flares, and then it is also correlated with lupus nephritis. So anti-dsDNA is quite an important antibody as far as SLE is concerned. Then antihistone associated with drug-induced lupus, and anti-neuronal, also known as anti-glutamate receptor 2 antibody, associated with CNS lupus. Then anti-ribosomal P antibody associated with psychiatric manifestation in SLE. Now don't confuse these two. Anti-neuronal is associated with CNS lupus, while ribosomal is associated with psychiatric manifestations. Both are different things. So basically remember P for psychiatric, right? Ribosomal P associated with psychiatric manifestation. So that's how you will connect the linkage. Then anti-UNRNP antibody associated with musculoskeletal and lung impairment in SLE, right? And in fact, even in systemic sclerosis as well. And in fact, U1RNP antibody is the most specific antibody for the overlap syndromes like mixed connective tissue disorder. So this is very important aspect. Overlap syndromes like MCTD, most specific antibody is anti-U1RNP. Then another important point is that women with childbearing potential and SLE should be screened for anti-phospholipid antibodies and anti-Rho antibodies, because both these antibodies have the potential to cause fetal harm, right? So as long as the SLE condition is active and these antibodies are positive, then we will advise the women to abstain from pregnancy, right? Because these antibodies have potential to cause fetal harm. Now, anti-phospholipid antibodies are important, specific for the APLA syndrome, antiphospholipid antibody syndrome. So there are basically three types of antiphospholipid antibodies. One is lupus anticoagulant, then we have anti-beta 2 glycoprotein 1, and then anti-cardiolipin. So these are specific for the APLA syndrome, and as we talked about, they have also the potential to cause fetal harm in SLE, right? Then we have the Sjogren's syndrome antibodies, anti-Rho antibodies, and anti-LA antibodies. They are also known as SSA and SSB antibodies. They are specific for Sjogren's syndrome. So Rho, La, A, B, right? They are specific for Sjogren's syndrome, and as we talked about, they also have the potential to cause fetal harm in SLE. Then we have systemic sclerosis. Anti-topoisomerase 1, also known as anti-SCL70, is specific for diffuse cutaneous variant of SSC, while anti-centromere is specific for limited cutaneous variant of SSC, right? So both these are specific and hence best for diagnosing systemic sclerosis. Just remember which is which. Topoisomerase for diffuse cutaneous, centromere for limited cutaneous. Then anti-RNA polymerase 3, this is associated with increased risk of renal crisis and malignancy. Anti-U3RNP or anti-fibrillarin, this is associated with increased risk of renal crisis, ILD, and pulmonary artery hypertension. So remember, anti-U1RNP had musculoskeletal and lung impairment. So anti-U3RNP also has lung involvement, except it also has renal crisis. Now, this is very, very important. Don't confuse U1RNP and U3RNP, right? U1RNP associated with a mixed connective tissue disorder, while U3RNP is renal crisis, ILD, PAH. So do not confuse these, right? This is a very important question. Most specific antibody for MCTD, the answer will be U1RNP. Then we have anti-TOTH antibody, anti-PM SCL antibody. So all these also are specifically seen in systemic sclerosis. Anti-PM SCL antibody is also specific for overlap syndrome involving dermatomyositis and polymyositis. Okay, then we have the ANAs in rheumatoid arthritis. We have rheumatoid factor. It is an IgM type of antibody, and it is not specific for rheumatoid arthritis. Remember, it is not specific, right? It is very sensitive. It is seen in a lot of patients with rheumatoid arthritis, but rheumatoid factor positive does not mean the patient has rheumatoid arthritis, right? It can also be seen in Sjogren's syndrome as well. Then we have anti-CCP antibody, also known as ACPA antibody. The full form is anti-citrullonated protein antibody, right? That's what ACPA stands for. Now this is the most specific antibody for rheumatoid arthritis. Rheumatoid factor is sensitive, but it is not specific for rheumatoid arthritis. It can also be seen in Sjogren's syndrome, but ACPA or anti-CCP antibody is the most specific for rheumatoid arthritis, right? Then we have dermatomyositis, polymyositis. Here, anti-MI2 antibody is associated with good prognosis in dermatomyositis, right? Then we have anti-Jo1 antibody or anti-synthetase antibody. As the name suggests, it is associated with anti-synthetase syndrome. Both of these can be seen in dermatomyositis, right? So these are all the important autoantibodies. Alright, so now let's begin with the immunostaining pattern of the autoantibodies. So this is the pattern which is observed under the microscope when we do an immunofluorescence staining of these autoantibodies. So there are 5 patterns: the homogeneous or diffuse nuclear staining pattern, the rim or peripheral staining pattern, the speckled pattern, centromeric pattern, and the nucleolar pattern. So first of all, we will take a look at which pattern is specific for which autoantibody, and then we will take a look at the images of these immunostaining pattern. So the first two patterns, homogeneous staining and rim or peripheral staining, are seen in SLE. They are suggestive of SLE. So homogeneous pattern is typically seen in anti-histone antibodies and anti-dsDNA antibodies, while rim or peripheral staining is seen with anti-dsDNA antibodies. So basically, anti-dsDNA can show both homogeneous staining pattern as well as rim or peripheral staining pattern. So both these antibodies are seen in SLE. Then we have the speckled pattern. Speckled pattern is the most common observed pattern, and since it is the most commonly observed pattern, this is the least specific pattern as well, right? It is the most common, thus also the least specific, since it can be seen in anti-SM antibody, which is specific for SLE, anti-U1 RNP, which is specific for mixed connective tissue disease, then anti-SSA and SSB antibodies, which are specific for Sjogren antibodies, and anti-topoisomerase antibody, which is specific for diffuse cutaneous variant of systemic sclerosis. So since speckled pattern can be seen in so many different conditions like SLE, MCDD, Sjogren, etc., it is not very specific for any single condition. Hence, it is the least specific pattern. Then we have the centromeric pattern and the nucleolar pattern. These are suggestive of systemic sclerosis. Centromeric pattern is seen in anti-centromere antibody, which is specific for limited cutaneous variant of systemic sclerosis. The nucleolar pattern is seen in anti-RNA polymerase, anti-THTO, anti-PMSCL antibody, and anti-U3RNP antibody. All these antibodies are seen in systemic sclerosis, right? So centromeric pattern and nucleolar pattern are suggestive of systemic sclerosis. Now let's take a look at these images of these staining patterns. Okay, so this is the homogeneous pattern. As you can see, the entire nucleus is stained diffusely, homogeneously. There is no speckling or no peripheral enhancement as such. The entire nucleus, this is the nucleus of the cell, and entire nucleus is stained. Compare this with the speckled pattern. Here you can see the entire nucleus is stained, but there are islands, dark unstained multiple spots, which gives the nucleus a speckled appearance, right? So this is the speckled pattern, which is the most common pattern, but also the least specific pattern. Compare this with the rim pattern. Now, as you can see in the rim pattern, the entire nucleus is not stained. Only the rim or the periphery is stained, which is enhanced. Homogeneous pattern, there is diffuse staining homogeneously, while in speckled pattern, there is certain dark spots on the diffuse stained nucleus. Then we have the nucleolar pattern. In nucleolar pattern, only the nucleoli inside the nucleus are stained. The entire nucleus is not stained. Similarly, in centromeric pattern, only the small centromeres inside the nucleus are stained. So it's a very peculiar appearance that multiple small stained dots are visible inside the nucleus. So this is how the centromeric pattern staining looks like, right? So this is the homogeneous pattern, then the speckled pattern, the nucleolar pattern, the centromeric pattern, and the rim or peripheral enhancement pattern. So this completes our discussion for this topic, and if you found this video helpful, then do drop a like and subscribe to the channel if you are new here. Thanks for watching, and see you in the next one.